Good afternoon, everyone, again. Welcome to our webinar on reopening too soon. This webinar is part of an ongoing webinar series. Many of you might have already attended some of our previous webinar series. And our series is organized by the Black AIDS Institute, the Multicultural AIDS Coalition, House of Blanca, Harvard University CFAR, and the Southern AIDS Coalition. We are a group of HIV organizers, advocates, researchers, and providers who felt the need to create a space where Black communities, Black people can engage in dialogue, where we could network, and where we can build action together. Um, a lot of these webinars and these topics build on the work that we've done in HIV. We lean on the lessons learned and know that there are much more that we need to do. And we know that our work intersects with the COVID pandemic and the other pandemics that our communities are dealing with. Before we get started, I want to let you know all participants are muted and are unable to share video. We ask that you use the chat box for comments and questions. This is opportunity for us to engage in conversation. We have some amazing panelists with us today. So there will be time later on in our time together for us to engage in conversation. So please use the chat box for your comments and for your questions. Now I'm going to turn it over to Gary Daffin, who's the Executive Director of the Multicultural AIDS Coalition. Gary?
Thank you, Chioma. Thanks everybody for joining us today. I think we have a really good group of panelists and a good discussion that is definitely timely. As Chioma said, this is a series of conversations that we're going to run through the summer. Last week, we talked about historic trauma, and I think that's a good precursor to what we're going to talk about today. We wanted to take a look at what's happening with the coronavirus pandemic and have a conversation about whether or not it makes sense or what we need to be thinking about as states, quote, go back to normal as they open up, some with restrictions, but most without restrictions over the next few weeks. So we want to encourage everyone to send comments. We're going to have a conversation that I think will touch on both that topic and what's currently happening. I think we could have called this session current trauma, given what's happened over the past week. And we certainly want to make sure that we incorporate some of how the current what's happening in America impacts the coronavirus pandemic. So what we usually do when we start these is to have a grounding exercise. And so we found a really nice piece that we want to share with folks. So if everybody can take a deep breath and relax, let your shoulders down and enjoy this.
You so black. You so black. When you smile, the stars come out. You so black when you born, the God come out, black is not. Black when it's wrong and black when it's right. Black is pyramids and mathematics. Black is melanized and magic. Black is televised and in need of drastic black advancement. Black enhances, black with chances, black with privilege, black with pride, black on purpose on the black hand side, black and beautiful, black and blessed and highly favored, praise the Lord, black and blessed, black and so much more, black and nothing less, black and educated, black is brilliant, black is strong, black is resilient, black is song, black is infinite, like hip hop or space, black is grace, black is love, black makes babies grow up, black is tough, black is hard to do. Black is me. Black is you. Black is not something we get to choose, but it is something we get to cherish. It's something we get to wear, and we get to rock this with honor. I'm black like my granddaddy and my great-great-great-great-grandma. Black is that lift every voice and sing. Black is that letting your freedom ring and resound. Black is adjective, adverb, color, and noun. You so black. Oh, you so black. When you smile, the stars come out. Baby, you so black. When you're born, the God come out.
So let's move ahead. So usually what we do is we have a clinical update. We have the panelists go and introduce themselves. So why don't we do that? Our clinician, Dr. Bisola Ojikutu, let me know that one of her colleagues got sick, so she's having to take care of some COVID patients today. So didn't think she could make it, but she may pop in. So we won't be having a clinical update this session. If you want to just introduce yourself.
Sure. My name is Greg Millett. I'm the Vice President of AmFAR's Public Policy Office in Washington, D.C.
Good afternoon, everyone. My name is Dr. Atia Martin. I'm the Chief I almost said I'm the Chief Resilience Officer. I'm the Chief Executive Officer for All ACEs, Inc., and we are a diversity, inclusion, and equity transformation firm.
Great. Hi, everybody. My name is Kenyon Farrell. I'm the senior editor of thebody.com and thebodypro.com, and also board chair for a new organization called Global Black Gay Men Connect.
Okay, great. Thanks. So one of the things we want to do is to, we've asked Greg to come on, and we don't usually have slides, but we want to have him give us an overview of some of the research that he's been doing recently and give us a look at what actually is happening out there with respect to the coronavirus. So Greg, if you want to go ahead, I think you can control your slides.
Great. Thanks, Gary. I appreciate it. And good afternoon, everybody. I'm going to try and keep this brief, and I'm hoping that it could help frame some of the discussion today. Certainly, some of it came up in the preamble that both Gary and Chioma gave. But I'm going to talk a little bit about Black America epidemics and structural racism and just give some brief snippets of what we're seeing across different health conditions in the U.S. Now, many of y'all might have seen this slide beforehand. This is from a big study that came out in 2006 where they followed 13,000 young adults over a period of time. And they were looking at white young adults and Black young adults. And they were looking at STD and HIV infection risks. So those red boxes that you can see to the right, these were the people who got STD or HIV. And this is for the white young adults. And what you can see is those people who engaged in higher rates of risk behavior were more likely to get HIV or an STD. When they looked at Black Americans, it didn't matter if you engaged in low or high risk behavior, you were more likely to get HIV or an STD. So it's very clear that risk is not driving HIV or STD in Black communities. And when you take a look at STDs across the United States, this was another paper from some former colleagues of mine at CDC who are looking at STDs among white Americans for chlamydia and gonorrhea. And you can see here that it's really spread all around the United States. When they did the same thing to take a look at STDs among Black Americans for chlamydia and gonorrhea, this is what they found. So we see that it's concentrated in the South for African Americans. And we know that there is a history that's there. There are policies that are there that also help to exacerbate why we see greater rates of chlamydia and STDs in the Southern United States, particularly among Black Americans. The other epidemic that I want to talk about is the opioid epidemic. Many people talk a lot about the opioid epidemic. It does affect more whites than Blacks, and there is a historical precedence for that that's based upon racism. But we also know that there are Black communities that are starting to catch up in use of opioids. And these are data showing that in Baltimore, Washington, D.C., Philadelphia, Cleveland, Ohio, Cook County, Chicago, New York City, that they're seeing these increases year on year on opioid and fatal overdoses in these cities. And these are cities with all large Black populations. Just in Cleveland, Ohio alone, they saw between 2014 and 2017 a huge increase in African-American overdoses that are taking place just in Cleveland, Ohio. But when you take a look at drug treatment by neighborhood, to treat opioids, you use methadone or buprenorphine. Most people like to use buprenorphine because you could basically take it off of your insurance and you can use it for your drugs in the privacy of your own home. For methadone, you have to keep going to a particular place every day, which would be difficult for some people who have their jobs to keep going to one place. But there's studies that found that Black Americans are more likely to be on methadone, and white Americans are more likely to have private health insurance and to be on buprenorphine, which makes it harder for Black Americans to get good drug treatment because they sometimes have to travel 2.5 hours away. They have clinics that are located in particular neighborhoods, and some of these methadone clinics are closing because of gentrification in many of these areas. And then there was another study that looked at different types of counties in the United States according to the proportion of African Americans and the number of substance use facilities. And you can see here in the year 2000, that as we went from increasing number of Black Americans in many of these counties, that you had a high number of substance use facilities, outpatient substance use facilities. By the time that we got to 2010, because of gentrification, you see this huge decrease in many of these counties that have large African-American populations. So even if we want to deal with the opioid epidemic in Black communities, we don't necessarily have the substance use facilities that we used to have previously so that we can deal with that. So again, another issue. We covered HIV, we covered STD, we covered opioids and seeing what's happening with Black Americans. Now let's take a look at COVID-19. With COVID-19, you see some other issues as well. We know that Black Americans are less likely to be tested for COVID-19, but we are more likely to test positive once we are tested for COVID-19. But unfortunately, there have been a series of reports. There's been reports in Tennessee, there's been reports in Philadelphia, there's been reports in several cities in Texas that show that COVID-19 testing is systematically not located in Black or brown communities where we're more likely to find those positive tests. And this is ridiculous because there are data out there, including a study that we published showing that there is an increase in COVID-19 diagnoses when you have an increase in the number of counties or proportion of Black Americans in counties, but we're still not seeing the testing going to where it needs to go. And part of the problem with the whole COVID-19 dialogue is that we keep hearing over and over again in the media that people keep talking about underlying health conditions such as heart disease or diabetes. And this again is a picture that you saw earlier where we see what's taking place in Black counties in the United States, and this is heart disease and diabetes. But that's not what's driving COVID-19. Our data and data from others are showing that it's the social determinants of health. So it's poverty, it's unemployment, it's uninsurance, all in these areas, plus many other issues that are driving COVID-19 cases and deaths. And quite frankly, that's also driving STDs, it's driving HIV, it's also driving the opioid epidemic in many ways as well. But for some reason, the national media, the administration, and many others don't want to talk about social determinants. And that's part of the reason why we're also seeing protests that's taking place all across the nation, because the structural issues, the structural racism is something that that our society does not want to face. So again, across many different types of epidemics, we're seeing a consistent pattern where there are structural issues that are placing African Americans at greater risk for HIV, STD, opioids, and COVID-19 as compared to white Americans. But there's this inability of American society to actually deal with the root issues that's placing many of these groups at risk. And that's it.
Thanks, Greg. I did want to ask you if you could talk for just a second about what you're seeing in terms of urban and rural COVID-19 infections and deaths. I know you've done some work on that, just to sort of give people a sense of it.
Sure. So the analysis that we published, we took a look to see whether or not there's any differences in greater COVID-19 cases in disproportionately Black communities in urban areas as compared to smaller metropolitan areas or rural areas. And what we found is that it didn't matter which geographic region you were in, that COVID-19 cases were higher in disproportionately Black communities from rural areas to small metropolitan areas to urban areas. And then when we looked at COVID-19 deaths, we saw a lot of the same pattern, but it was pretty interesting because for COVID-19 deaths, we see that among Black Americans, it's being driven in primarily small metropolitan areas and in rural areas. I mean, think about, you know, the funeral that took place in Albany, Georgia, where there was a large group of African Americans who became infected with COVID-19, and then quite a few who died. It's that's driving deaths within our community. So people who think that this is just an urban area phenomenon is wrong, COVID-19 is affecting all of us across all of the US.
Thanks. Dr. Martin, Atia, I wanted to ask if you could talk a little bit from your perspective of having been Director of Public Health Preparedness for the city of Boston, and maybe some of your resiliency work as well. And what you have been seeing or what you've been thinking as you've watched states, many in the South, even though they are experiencing increasing coronavirus infections, increasing deaths, what's your perspective on their decisions to open up, if you will? It doesn't seem to be a lot of preparedness, in my view. So wondering what you've been thinking from your perspective of having done that for the city.
So thank you for having me. It's an absolute pleasure. I struggle with all of this because as someone who was a professional emergency manager, meaning learned from some of the best, trained, got certified to be an emergency manager. When I look at what's happening in communities, we're not even doing the basics of best practices. And so whether you use the emergency management cycle, whether you use the public health approach, whether you use critical thinking, whether you use the scientific method, pick a process, and it always begins with what is the information telling us about where the challenges are most highly concentrated, and then reverse engineering to see, okay, what's the context, right? Because you need the context, the data isn't enough. And then once you have the context, which really is about the experiences, the narratives of people who are being impacted, then you begin to take targeted approaches and interventions in order to address the issues, right? Like, this is not rocket science. And so you don't need to be a certified anything to understand that this is how we should be approaching things. This is how we have always done it when we have done this work well. And so for me, you know, at the most fundamental levels on the emergency management side, you know, when you are dealing with a pandemic, public health, our public health departments, our local public health departments, our state public health departments really are supposed to be taking the lead role. And they're supposed to be the ones making sure that all of us get the data that we need on a regular basis to understand what is the impact. They're supposed to be the ones who disaggregate that data, meaning they're not just giving you totals and sums. They're breaking it down by race. They're breaking it down by gender. They're breaking it down by neighborhood. They're breaking it down in all the ways so that we can see the nuances of how this thing is playing out. In this case, COVID-19. And so those things are not happening in real ways. The data around testing, where are people being tested? Of the people being tested, who is actually showing up positive? How do we make sure that they get the support that they need? So it's not just a medical approach, that we're actually using our, again, best practices around how we support people and all the things that people need, not just the medical aspects. We shouldn't ask people who have tested positive to then get on a bus and go back home to self-quarantine, because now they're infecting everybody that they're coming into contact with potentially. And so there are just some really troubling missteps that have taken place, as if we've never been here before, as if we've never planned for this, as if we've never talked about this, as if we didn't spend billions of American dollars on pandemic flu preparedness since H1N1. So that's kind of where we are. And I think it's important for people to understand what it was supposed to look like in terms of the response, so that folks can advocate for their jurisdictions to be doing it the right way, to be following their own recommendations on what we're supposed to be doing in our communities, and that community grassroots people in the community have that information so that they can be in a position to hold these folks accountable, because everyone keeps saying this is unprecedented. We've never been here. We couldn't have possibly imagined that we'd be here. No, we actually did. We've been talking about it for at least 11 years since H1N1. And so this idea that this is all brand new is totally false. And I'm happy to share some links as we go through so that folks have the information they need in order to do the advocacy work at the local level.
So Kenyon, I know you have lots of thoughts about this. I do want to get in my media question to you. Related to communication, I mean, what Dr. Martin was saying, a big part of that is communication. So I'm just wondering if you, looking at what has happened over the past 3 months and how this pandemic and what's been happening has been communicated, and particularly around Black people, Black and brown people, it seems like at the beginning that was not a focus, and then there were sort of inklings and we were demanding to get more data, more information, and suddenly became a big focus. And as it became clear that the biggest impact was on Black and brown folks, particularly Black people, we also saw the emergence of a insistence that we go, quote, back to normal. So I'm just wondering if you have any thoughts of that, if you've thought about, you know, how that has played out over the past 3 months.
Sure, thank you. Yeah, I've thought a lot about it, both as a, kind of working editor for, 2 websites that serve, people living with HIV, people concerned about HIV, and also for providers. And frankly, this whole, the coronavirus sort of terrible example of communications actually made me consider going to get my PhD in health communications, because I think it's so much a piece of the puzzle that I think this really showed a real lack of leadership just in basic communications. So first of all, I'm in New York City, and I remember I remember in late February, around like 25th, 26th, I was actually a keynote speaker for Black History Month at the New York City Department of Health and Mental Hygiene. And that day, some of the more senior folks at the Department of Health could not make my keynote address because they were in a meeting about COVID-19. So this is late February, right? And it was a concern at that moment in late February that there were potential cases in New York City in Queens. But it was several weeks after the fact before there was any sort of public acknowledgement or conversation about that reality. And part of the way it was constructed here in New York was, this was, people in Westchester County, and in a particular town in Westchester County, which is mostly a kind of white, wealthy town, which is right next door to Mount Vernon, which is mostly Black and brown folks. And so to me, what was so interesting is the state response started to roll out. The first testing center was in that white suburban town. Again, right next door to another Westchester town that is mostly Black and brown. We were told initially that you didn't need to wear masks, right? I mean, I know that part of the concern was, one, we're dealing with a new, virus that we're still sort of learning something about the ways in which, the sort of biology and virology of how it sort of, gets into systems. But we were told pretty much unequivocally that, don't worry about masks, save masks for essential workers and providers, which in that sense made sense. But this is because, as Dr. Martin pointed out, we were ill prepared from the beginning to actually have enough masks for people who were going to be providing care to folks, in this situation. But we were told initially that we didn't need them. That, of course, changed. We were told then there was the, social distancing, whether to wear gloves or not wear gloves, all of these sorts of very confusing messages, from the very beginning that have been problematic. And of course, what has happened in that also reality around, kind of race and how this played out. I mean, there were some people who initially myself included, I was on a show in early March saying, this is probably what's going to happen if we already know that, you know, type 2 diabetes and some of the underlying kind of health conditions disproportionately impact Black people. We are in a situation we may potentially see this impacting Black folks worse, and also knowing that Black folks are going to be primarily in service-based jobs and labor where they're not going to be able to take off and just work, or just work from home and still be paid. That this is going to partly create the context for what we're seeing, but it still took a lot of pushing from community activists to get some acknowledgement from the federal government that this disparity, if you think about it, we only started talking about the racial disparities from the feds sometime in April, right? A good month into what was already known, you know, what was going to happen. So, so I think that I would say, yeah, we've had a major problem with kind of getting accurate information, and coming from communities that already are suspect and have a range of distrust of healthcare systems anyway. All of the confusing kind of messaging, frankly, left a window open to some of the kinds of conspiracy theories that we also saw float around the internet, that if you're like me, you had to talk some uncles and aunties off the ledge around, you know, in the sort of first weeks, you know, entering this process. And so just, I would say in closing, moving forward, one of the things that I think that we need, you know, in particular as Black folks who work in public health, I think is, you know, kind of early on to really be strengthening our sort of networks and really promoting our folks to get it ahead of news and get in the news, to be talking to Black folks about, you know, what, you know, any sort of health condition or pandemic or infectious disease might mean for them or their loved ones, and not wait on the government to do so.
And so I just want to go back to Atia. From that perspective, I know you're doing a lot of work within the community in terms of responding to COVID-19 and other issues. And I'm just wondering if you could talk a little bit about, given that we need to be creating our own networks, creating our own information channels, and figuring out, not that we can do everything for ourselves. It's not our responsibility to do everything for ourselves, but just wondering if you have insight about what communities can do and should be doing.
Yeah, so first I want to acknowledge in this moment, the heaviness and the sense of helplessness and hopelessness that it can make us feel. And in spite of that, there's actually a lot that we can be doing. So one of the things that we're doing in Boston through the Black Boston COVID-19 Coalition, which my nonprofit is one of the two. So the business I mentioned earlier that I'm the CEO of is All Aces Inc., and that's the diversity, equity, inclusion work. But I also have a nonprofit that's locally focused. And through that nonprofit, we pretty much are the backbone organizations for the coalition. And what we've done is said, we have to do both, right? We have to hold institutions and folks who are making decisions about resources accountable. And we have to do all the things that we can do within the community to take care of ourselves to the best of our ability. And once we started doing those things, we realized there was actually a lot we can do. So for example, the city was putting out data that you basically have to go to their website every day to get the death data, but they don't report it over time. So it's hard to understand like where we've been, where we're going, what the differences have been from day to day. And so we started going in and pulling the data and putting it into Google Sheets and tracking it ourselves and creating charts and sharing that with the community to show the disproportionate burden on Black people in Boston. We also did a lot of work around how to also do that with the cases, the number of cases that are happening on a regular basis. And then looking at how do we get masks to people to deal with the short-term response issues? How do we get gloves to people? How do we help people understand good quality information, to Kenyon's point earlier, which there's a lot of misinformation out there that we've had to dispel. So we set up a website, blackbostoncoalition.org, where we then started posting like good quality information about things people should be doing. Anecdotally, we've had one of our steering committee members at the grocery store had given the website to a woman because she had asked her some questions and it was clear that the woman didn't have good information. So she gave her the website, bumped into the woman a couple of days later at the same grocery store. And the woman thanked her for sharing the information because she didn't know all of those things, right? And there's a lot of information out there, but it's hard to suss out what's real and true and what is propaganda and what is just someone being an opportunist to get clickbait. And so, and I say those are the things that we can do, and the different ways that we hold our elected officials accountable. Protesting is one way, right? One part of a larger strategy, and it's also about making sure that we are taking control of the narrative. Someone had put in the comments that they, are concerned about kind of white people taking over our narrative, right? And so the way to combat that is to constantly be putting out our narrative, right? And making sure that we are telling the story from our perspective. And I think that's really important, especially now. Especially since the mainstream media narrative is related to what was the presentation we saw earlier, which is Black people do these things to themselves, right? We get ourselves sick with COVID. We, get ourselves killed by the police. We do these things to ourselves. And the reality is the data, the facts of the matter are very different from that narrative. And so it's important that we are constantly out there controlling the narrative and partnering with our white accomplices. I mean, not allies, accomplices, because there's danger in really, really, really aligning yourself with Black people and really, really, really doing the work. And that they are towing those same lines when they're out in the world kind of speaking as well, that they're using the narrative that we give them as opposed to whatever the mainstream narrative is. And then the last thing I'll say is, this is long game. I know we want change tomorrow, right? Like it would be amazing if there was an equation that we could just put in that would magically like be the racial equity thing. And we would just magically end up in a place where like all of our issues were addressed. The challenge is that's not the reality we're in. And so there are short-term wins we can gain by also looking at who are the people who are aligning themselves with our elected officials who are not listening to us, and reaching out to those people too and saying, hey, we have these demands. We are not confrontational people. We are calling them demands though, because we are demanding our return on investment. We're not asking for charity. We're not asking for sympathy. What we're asking for is a return on our investment in the cities that we're in the states we're in this country that we for generations have not received. And that for us, the opportunity here is that we can be partners in this. And so will you support our demands, which are very realistic? So that means that our demands have to be really specific and realistic, and we have to have like workshop them in with ourselves, iron sharpening iron as a community, but really being clear about what it is that we're asking for, and asking those folks who are very visible to take a position, right? So in being clear, like we're going to share with everyone, all the folks who said they support our demands. We're also going to share the folks we asked. And people will be able to see the difference between who we asked and who actually supported us. And so the more tactics and strategies we can use that are based on the behind the scene closed doors conversations we need to have as a Black community, that are researched, that are built on strategies we've used, that are time and experience tested, because there's a lot. We have done a lot of amazing things as Black people. And so there's a lot to learn about those strategies. And then there's also things like the art of war, in terms of not that we're talking about violence, but we're talking about tactics and strategies, right? And there's a lot that we can be doing that it's hard to see because of how the world tries to paint us into a corner around what our level of power or capabilities or agency is. So I'll stop there and say thank you for asking that question, because I think it's really important for us.
So I want to come back to Kenyon in a minute about the art of war and some other questions. But you mentioned that this whole idea that, I mean, I know, Greg, I wanted to ask you about this idea of underlying conditions and this idea of people sort of blaming Black people for their own health issues. And I wanted to ask if you could talk about that, but also about like, what is some of your research saying in terms of what's associated with people having COVID or more likely to become infected in terms of, you know, things like unemployment, other things?
Sure, no, I appreciate that. So what we found is that COVID-19 was associated with being unemployed. It was associated with not having health insurance, and it was associated with the number of people that you had in a household. So, you know, number of people that you have in a household, of course, makes sense. Not having health insurance certainly makes sense. Some people were scratching their heads when we said unemployed. But we asked them, you know, you have to consider it. The fact that African Americans work in jobs that are more likely to put us in exposure to COVID-19, being unemployed is a bit of a protective factor. So that's, you know, where some of those data were coming from. And what you see is that, you know, it's really these social determinants of health that are driving this. And I think it's a shame, unfortunately, that we still don't have enough disaggregated data by race and ethnicity across the United States. When we started our research study and capped the data at April 15th, by then CDC said that as much as 78% of the data by race and ethnicity for COVID were missing. I was on a call last week with CDC, and now we're at 54% of the data that are missing. So we still have an awful lot of data in terms of race or ethnicity that's just not out there. That really needs to be disaggregated. But in the meantime, we can certainly take a look at the data in terms of some of the counties that are available. There's one thing that I did want to share, and I think it, you know, really goes to Dr. Martin's point in terms of that we knew about this earlier. You know, just 10 years ago when we had H1N1, H1N1 was another clear respiratory disease that was also a racialized disease. It affected particular communities, and it affected communities of color, where you saw higher rates among African Americans, Latinos, Asian Americans, as well as American Indians. So it's something that we knew about. We knew that this possibility was out there. And this is actually a graph from CDC. So it's a shame that here we are in the midst of this pandemic, where we knew that these communities were going to be at higher risk for this type of infection. But we were still caught flat-footed. We weren't able to actually address this in a way that was comprehensible, and to make sure that as many African Americans and Latinos didn't become infected and eventually die from COVID-19. And one last thing that I also want to mention is that we're seeing a lot of people in HIV who are researchers, who are at the forefront of the COVID fight. And it's great to see them there. I'm a researcher myself. I'm happy to see a lot of colleagues who are doing this work, but we're only half of the equation. There are some amazing HIV community-based organizations that have been doing some incredible work that really understand stigma. They understand how to deliver testing to individuals and communities. They understand a whole array of things that we know that are specific to many of our different communities, but they're not receiving the funding. They're not being invited into this space. And there needs to be a lot more work done to make sure that we get these CBOs with their expertise really to help inform the COVID response. After our paper was published, we had Senator Warren, Senator Harris, and Senator Scott all reach out to us. We spoke with the Congressional Black Caucus as well in Congress, and we conveyed that message to each one of them, that it's great that we're seeing HIV researchers doing this work, but there's an awful lot of expertise with CBOs that also needs to be tapped, and we need to figure out ways that we can get funding to those CBOs to do that type of work.
Right. So now back to Kenyon. And I want to take up that question with you in terms of what's the role of, I mean, HIV organizations, HIV community in general. But another question I think that Greg raises is sort of what is the role of CBOs who are in HIV and other health-related fields? What do you see us doing in this moment?
Yeah, I've been thinking about this a lot. I think that one, there's a huge role, I think, for kind of community-based organizations that have been HIV focused, you know, in COVID-19 and frankly, a whole host of issues. I think first and foremost, CBOs where, you know, kind of health concerns and especially dealing with, you know, the kinds of stigmatized conditions like HIV or other STIs, et cetera, and working in broadly Black communities, but also a lot of CBOs have relationships with faith-based institutions. They also work with kind of folks who are homeless or formerly incarcerated or sex workers or just a range of folks in the community in a moment where kind of access to information and people are going to, and people just in general, and there's research that bears this out. I mean, people receive information from people that they know and trust first, right? Even if that information turns out to be wrong, they're gonna go with the person that they know and trust, right? And so, but our organizations actually have those relationships in communities. And I think especially in this moment where there's so much focus on what we need to sort of open back up is about contact tracing and testing. Who better than like HIV community-based organizations to do that work? They know how to do that. You know, they do that work to some extent in terms of partner notification and, you know, working with folks as, bringing folks as, you know, partners in for testing and et cetera, those sorts of things. Folks know how to handle that information sensitively and more culturally competent, but we're not seeing those organizations be brought into conversations about what contact tracing looks like. I mean, here in New York, and we wrote a piece for it at the Body where our, you know, mayor made the decision to move resources and the sort of direction for the contact tracing program for COVID-19 to the City Health and Hospitals Corporation, as opposed to the City Health Department, determined by our reporting to be mostly about a bunch of petty drama, right? And not actually about the institution that makes most sense and that has the history to do that work. So I think to me, we should be speaking up a lot more about the role of contact tracing will play in terms of addressing COVID-19 pandemic and specifically arguing for community-based organizations like HIV CBOs that already know how to do that work to, one, help inform those strategies as they develop across the country, two, that they receive funding to do that work, and that they also receive funding to train and support other kinds of institutions that will be involved in that work, and that we also set some sort of guidelines for what that looks like so that we don't end up using that infrastructure to create another kind of criminalizing or punitive measures for people, say, who don't you know, social distance or standard. It should not become a replica for police, right? Our public health systems should not be sort of replicas for, or kind of avatars for the policing entities in our country at the same time. And I think if nothing else, if you didn't believe that before this past week, should have probably, you know, told you that should be the case, that we have to really rethink how we work in terms of public health in ways that don't collude nor model the criminal justice system.
So there are a couple of questions that are kind of related to what you're saying. People were asking about how can large institutions be helpful? And I know in Massachusetts we have a very big contact tracing or ambitious contact tracing effort happening, and the state is certainly partnering with some of the larger community health centers to do that work. But interestingly, they have, for example, with my organization, they've called to say that what they're finding is that some of the people that they identify that need to isolate need a lot of help. They need sort of help figuring out how to do that in their space that they're in. They need other kinds of issues. So they want to help. They want some of the community-based organizations to help them on the ground to figure out how to provide that extra support to folks. Because it's different if you're someone with means and with ability and capacity to just stay in your house or go to a hotel.
Right.
It's different if you live in a house with 8 people and you have 2 bedrooms. So that's it's a complicated issue. And the criminalization piece is obviously very important. And so I just want to ask Atia, in terms of what you're seeing in communities, maybe some of what are the issues that, have you seen any issues related to contact tracing that might be a barrier to folks wanting to participate in the program, shall we say?
I would say all of it. So I can speak for Massachusetts. Massachusetts contracted with an international NGO to come to Massachusetts to do contract tracking and tracing work. There was a huge hiring process. So number one, the hiring process failed because they didn't strategically make sure they were hiring people from the community, right? Secondly, when they started, and there was no transparency on then who got hired. So there was these conversations about, oh, we're hiring, make recommendations. So that's what folks did. And then there was a black hole. And then all of a sudden we found out people were hired, but none of the people that we had recommended. The other piece is because of that, you have people in the community who are not picking up the phone when these people call. And so, it kind of makes it hard to do tracking and tracing if people don't answer your call. And furthermore, there's no app that is going to quite do it, especially since we have a huge digital divide, both in terms of access to technology and access to good quality broadband and wireless connectivity. So there, at every layer, we failed. And so, so right now, and it's not even clear where they're reporting the information about the contact tracking and tracing. I don't know where to go to see, oh, these many cases have happened and we've reached out to this many people in these neighborhoods, and that it's a black hole. And the point I want to highlight in all of this is these aren't just Black issues, right? Racism, because of racism, it's worse for Black people, right? But the reality is that these are flaws in our systems and our structures and our policies and our elected officials in the process, of even just getting information to people. And so we are disproportionately bearing the burden. It hurts more for us, but make no mistakes about it. Like, these are signs and signals that the whole system is messed up for everybody. Like and it's the very few people who have resources and connections and relationships who can navigate through the dysfunction to get what they need out of it. The rest of us are just struggling through to survive.
I have one big question that I'm going to save. The next question, though, I wanted to ask one of the in the chats, someone was asking about the difference in the response between the South and the North. And I don't know if Greg, you have any particular input on that, or Kenyon, if you've been following that from your magazine's perspective. Greg, do you see a difference in public policy response, public response?
Yeah, so there are definitely some differences. I mean, we know that COVID-19 started primarily in the Northeast as well as the West Coast, and now it's making its way to other parts of the country, just the way that the HIV epidemic did. I mean, all of this is very predictable in how some of these infectious diseases spread across the country. What we do see, though, is that there is a decidedly politicized version of how we take precautions or deal with COVID-19. So we see on the Northeast, we see on the West Coast that people believe in social distancing. When you take a look at social distancing data based upon cell phones, you see that people are social distancing in those areas by and large. When you take a look at those same data, particularly in the Southern United States, you see that they're far less likely to social distance. And now Granted, many places in the South, it's a little bit more rural. There's more distances that are available. So, and we don't have as much COVID cases there yet, even though it's moving towards it. But it's still something that's very political. There's a Princeton scientist who published a paper in Vox. It was an article where he was taking a look at some of the social distancing data. And what he found was that those counties that didn't believe in global warming were less likely to social distance. And those counties in the US that also had higher support for President Trump were less likely to social distance. So there's some clear politicization that's taking place there. And we already know that President Trump has very high approval ratings in the South. I think it's no surprise to any of us. And this is really part of the reason why you titled this webinar what you titled it. It's no surprise to any of us that when we started reopening in the US, that the most aggressive states to reopen were in the southern United States. And that's part of the reason why we released our data so early before we even went to publication at the journal, because we knew that once we started to reopen aggressively, that the brunt of that was going to be borne in particular communities, primarily Black and Brown communities, and primarily Black and Brown communities in the South. And we wanted to make sure that policymakers were aware of that and that they could actually try and change or blunt what was going to be taking place. I mean, even take a look at the whole issue of wearing a mask. Wearing a mask has become politicized, and you're actually seeing some businesses, particularly businesses in the South, that are actually posting signs saying, this is a mask-free zone for some of these retail stores, where they're telling people if you wear a mask that you're going to be kicked out of the store. So it's a shame that we're at a time right now that science is being questioned, that facts are not necessarily making it through, that we have a cult of personality that is holding sway in particular parts of the country that's keeping people from taking precautions. Because one thing is very clear, coronavirus or any other infectious disease does not care what political beliefs that you have. It's going to infect you just as easily as it's going to infect any other individual. And we're clear that there's probably going to be a resurgence or even a peak of cases as well as deaths that are going to be taking place in the southern United States over the next couple of weeks.
Right. And Kenyon, I'm wondering if you've heard, anecdotally or in your work, heard much about what's happening in the South?
Yeah, I mean, much of what Greg just laid out, I mean, I would just say too, that in terms of a response to that, that there, luckily have been some calls that haven't gone, the full extent, but people have been asking the question about like the fact that most of the southern states also didn't expand Medicaid through the Affordable Care Act. And so what the damage, and so we already knew that their kind of health systems were damaged because a lot of the rural hospitals in the southern states have been closing for the last 10 years because of that decision. And now, so you have a situation where you have rural hospitals that have been closing over the last decade. And now you have a pandemic through which people have no insurance. And even here in New York, where, Medicaid was expanded and like the whole the state assembly still had to pass some laws about certain things in terms of COVID testing and care, still creating some funds for people to be covered in case their insurance didn't cover certain aspects of care. So it's not like we're out of that either, but there's at least some baseline of care here that in a lot of places in the South doesn't exist because of that decision to not expand Medicaid, which is partly, again, about people being able to have just the insurance for coverage, but just the other kinds of resources that Medicaid expansion created to help people shore up their health departments and have adequate, kind of staffing and hiring and data collection, which we also know in a lot of the South is, from the HIV data in the South, some of the data collection issues are the data is not good in a lot of states, frankly. And so this has created another kind of leverage point for, Medicaid expansion in the current conversation. But obviously no states have additionally expanded at this point because of it.
Right. So obviously what's been happening in the past week has traumatized all of America, particularly Black people. But I wanted to ask the question, and then we can go from here. Is one thing that seems to be emerging is this idea that racism is a public health crisis, or something that we can now say causes things, and then in the unscientific way of saying it. And I'm surprised that we now see conversations on CNN, whatever, and people coming in to talk about how racism as a thing in and of itself, not as an individual character trait, but as a living thing, is affecting Black people, particularly with respect to coronavirus, and now with the what people are finally calling the epidemic of police violence. So I'm just wondering if what has been happening in the past week has been rolling around in your mind with respect to coronavirus pandemic, perhaps the HIV epidemic as well, and how these things are intersecting. I mean, Greg talked about several different public health challenges. We have this concept of syndemics that we're now maybe adding to that racism, and I'm just wondering if you thought about that, and if somehow this is a moment that we need to think about how to incorporate that in our thinking or talking. I know that's a complicated question, but I always ask complicated questions to myself. So I don't know if anybody wants to take that on to start.
I guess I'll start. So we've been talking about racism as a public health crisis before COVID-19. Mm-hmm. And I think a lot of people don't understand what that means, because a lot of people don't understand what racism is. And so it's true, and it is one of the most powerful social determinants of health. Racism is, but the general public doesn't have the type of understanding of racism that matches the complexity, and therefore that concept is foreign to a lot of people. So in order to really understand that concept, you have to understand that racism as a system includes us as people, and it includes our institutions, and it includes all of the ideas that undergird the oppression that we have been dealing with since before the country was a country. And so I think in order for people to really get it, they need to understand that complexity and how all of it is layered, and how it shows up in organizations, and how there are a lot of the ways that it gets perpetuated is through almost like these qualities of oppression, right? It's like exploitation, right? We think about people in ways that are competitive and that are extractive, and our behavior is extractive, and so people don't get the credit or the resources or the things that they have actually earned, because somebody else has exploited and tapped into those resources. And so there are all of these patterns that we see around how oppression plays out. And I bring that up because it impacts us as Black people too, right? So we are also part of the system that we keep talking about, right? And if we as Black people don't also understand these issues and have racial equity literacy, then it makes it really hard to then in moments when racism shows up, whether it's at the interpersonal level or it's at the institutional level, that when it does show up, that we know what to do, because it's hard to know what to do in the face of something and freestyle it, right? Like, it actually takes practice and thoughtfulness, and it's a skill. And so I say all of that in the context of racism as a public health issue, because as we think about the implications of what that means, we have to bring people along with us. And I think in public health, we don't do a good job of bringing people along with us. Like, we come up with these amazing philosophies and concepts and framings, and they're awesome. And we pat each other on the back, and we talk about them at conferences, and we put out papers and stuff, but the general public is not with us. Like, we haven't put it in language that they can wrap their brains around, so that they can be in the same conversation with us and can be a part of the same advocacy, and can be there with us in lockstep. And so I just wanted to kind of highlight that. And clearly it is a public health crisis. And there have been tomes and tomes and tomes of studies that show us that the direct, not even just correlation, there have been studies that have gotten to a causation level of racism and health impacts, everything from how doctors interact with us, and the assumptions that they have about Black people. There are still doctors who think that our skin is thicker, and like that we suffer less pain, and like in medical today, right today, there are doctors who believe these things. And so for us to understand like that as a public health crisis, it's all of these layers. It's the doctors, it's our public health departments, and some of the paternalization that we have contributed to the problem. And so I say all of that to land here, which is we all have to take responsibility for ourselves and the organizations that we have influence over, as we talk about racism as a public health crisis, because we in public health are guilty too of perpetuating racism, right? Even as we have been staunch advocates, right, in bringing this to the forefront, we've also been guilty of, through behavior and even how we structure our organizations, and how we engage with community, in doing things that actually help to facilitate oppression.
Yeah, I agree with that response entirely. And it was just an incredible and comprehensive response. I think the only thing that I would add to it is the degree to which we can consider what racism is going to look like in terms of our response to COVID-19. The thing that I worry about is I worry about the fact that we are going to have therapeutics, we're going to have a vaccine that'll come online in the next 2 to 3 years. And because of this history of racism, because of this history of mistrust that both, Dr. Martin as well as Kenyon brought up earlier, that African Americans are less likely to take those drugs. And that could put us all at increased risk. I mean, the legacy of Tuskegee looms large still. There was, I think, a paper that was published back in 2002, 2003, that looked at a representative sample of African Americans around HIV. And as many as 50% of us believed that HIV was man-made and that the federal government had a cure for HIV. And they went ahead and redid that study in 2016. And it was still durable. They found that 40% of African Americans still held those same beliefs. So this is something that continues over time, that is going to be difficult for us to really address, because there's a history that's there, that people understand that something has taken place where the community has been wronged, and there's that innate mistrust, and that is going to be an issue for us with COVID-19. I think the other part of racism, as well as what Dr. Martin was also talking about in terms of providers. I mean, I already gave data showing what's taking place with testing, and the fact that testing is not even placed in the neighborhoods for African Americans or Latino Americans for COVID-19. But I think we're going to have issues too in terms of just access to any type of medical innovation. We've seen over and over again, when there's a new medical innovation, the communities that need it the most are least likely to get it. So think about ARTs. ARTs came online in 1996, but we saw for well over 10 years that mortality rates for African Americans for HIV was still far higher compared with whites, because African Americans were still less likely to have access to an ART because of health insurance and many other issues. We're seeing the same thing with pre-exposure prophylaxis. We have PrEP that's available, but we see over and over again that African Americans and Latinos, despite being at higher risk for HIV, are less likely to have access to PrEP. I fear that we're going to see the same thing as well for COVID-19, that once we do get some of these new medical technologies that come online, that the access is not going to be there for the communities that are disproportionately impacted. So, for me, it's sad to see that, past this prologue here, we keep repeating the same patterns over and over and over again without actually learning lessons from the near past or even the distant past.
Yeah, and I just quickly add kind of co-signing on everything that was just said. I think one of the things that I think I'm concerned with is from kind of us and other kind of advocates, whether in the sort of, you know, criminal justice space or within like public health, is this, you know, part of our sort of desire to create a sense of urgency and alarm is that, you know, you hear, COVID-19 is a Black disease, or, you know, these sorts of like frameworks. And I get what people are trying to do with that. Or that being Black is the pre-existing condition. Like, you hear things like that, right? And I get concerned with that kind of rhetoric because I understand the impetus for it. But I think going back to, I think something that Greg and Dr. Martin said earlier kind of alluded to this point that, like, we actually need to be very careful with that and actually start to talk about what are some of the sort of structural things that actually being Black is not put you just by virtue of, you know, racial identity and ethnicity or whatever to put you at disproportionate health conditions. There's nothing about us genetically speaking that is such, but that actually the systems of actual racism and white supremacy that structure the world in such a way to make it so. And so I think that we have to be kind of insistent and think about how we message kind of the impact of racism on Black people. And this other thing I would add too is that, I have said to a lot of my, having worked and done a lot of organizing and kind of around like kind of mass incarceration and police brutality and those sort of things for a long time. But I often, having working in public health, get sort of sometimes frustrated with us as Black folks, and that, you know, we will launch massive mobilizations and demonstrations when one of us unfortunately dies at the end of a police revolver. And not to say that we shouldn't be outraged about that, and all the stuff that we're seeing on the streets right now is completely legitimate. So let me be very clear about that. But also, if we compare the number of Black people who die through more mundane means because of environmental racism and toxins, because of all these other sort of structural, kind of issues that predispose us to premature death, usually through some kind of health condition, HIV, cancer, et cetera, there's no such mobilization, right? Or when we know hospitals are places that, like what happened in Baltimore a few years ago, where a woman who was mentally ill was put out the hospital in a gown, in like an open back gown, on a winter night in Baltimore, Maryland, right? Like the mobilizations have to happen around those things as well, right? And so I would say, just in closing, that, one of the things that that I think we also need to just talk more about, and kind of connecting these things together in terms of like mass incarceration and policing, and then like public health and other sorts of issues, is part of the reason why, we have the kind of policing apparatus that we do is because of priorities in government spending. So we don't have the same resources for public health infrastructure, for research and development, for access to medications, for healthcare, for education, for all of those sorts of things, because we spend so much money and resources on policing and prisons and forms of surveillance. And I think we have to start kind of like putting those two things together more, so that we're not just like in a kind of combative mode around, and somebody I see in the chat said, and military, absolutely, militarism and the kind of policing piece go hand in hand. So, we have to start to sort of draw like that this is where our money goes and not to these things, in a way to sort of talk about what the value of Black life means, also investing in these other sorts of systems that we need and everybody else in the country needs as well. So that's it.
Yeah, no, those are all very, very good points. So I guess in the last few minutes, I wanted to ask, I have thousands of questions I could ask, but I guess I wanted to ask if people are optimistic about anything at the moment. I mean, is there an opportunity in what is happening, in the mobilization that's happening around the police brutality, but also there is an awareness around the coronavirus pandemic that has people paying attention to public health for the first time ever. And I'm just wondering if people see any opportunities or particular dangers in the near and longer term.
I'll quickly, I'll say the danger first to get the bad news out of the way. I think that the thing that I'm afraid of, if the current situation continues around COVID-19 and the racial disparities that we see, is that, if we have a number of sort of stops and starts about reopening and shelter in place and opening and sheltering in place, that Black people, Native American communities, which are also being really hit on some reservations right now, and other communities of color will be blamed for the country not being able to open up, right? As opposed to all of the failures of public health systems to implement strategies to, prevent the pandemic from getting worse in the first place. So I have a fear of that becoming the dominant narrative, that y'all won't do the right thing so that the rest of us can get back to Taco Tuesdays and Sunday brunches or whatever the hell. So that's a fear. I think what's kind of exciting, or what's interesting, I do feel like even, in the kind of horrifying, things that we have seen in terms of, police homicide and violence and aggression in the last 2 weeks, none of which is new to any of us, but just the acute issues in the last couple of weeks. I do feel like I hear some different conversations happening, both in the mainstream press that I have never heard before in the mainstream press. A lot of the ways in which I feel like Black communities have talked about this stuff for a long time, I'm beginning to see, I pay attention to kind of shifts in rhetoric and narrative and how things get framed in press. And I do feel like I'm hearing a different concern and a different sort of way of talking about some of these things that I think, and just the diversity in people who are showing up at these different demonstrations, to me, does actually make me hopeful to some extent. So that's my
I'll just go ahead and be brief, because Kenyon basically mentioned a thing that makes me hopeful as well, is the diversity of people who are showing up to really protest all of this. I'm 52 years old, and I have to admit that if we had this conversation, and we've had these conversations back in the 80s or the 90s, it would be a very different conversation. And the conversation really would have been a lot of blame placed on communities of color, exactly as Kenyon was saying, in terms of what are you doing that's placing you at such high risk for COVID-19? Why can't you just go out and take care of your diabetes, or why can't you eat right? I mean, some of that type of rhetoric that you heard over and over again. And the same thing would have been said too in terms of the rioting, is, why are these people so angry? Why are they destroying their own neighborhoods and everything else that you would have pervaded the media that you don't necessarily hear as much now. Looking at the years ahead, I'm particularly heartened by the fact that the demographics of the U.S. is changing. By 2045 or so, this is going to be a majority Black and brown society. And a lot of the policies and issues that we've all been hitting our heads up against for so long, those are going to have to change. Either they're going to change now, or it's going to change in 20 years, but change is coming. That's something that's very clear. And you could see that even in the way that many other Americans, irrespective of their race or ethnicity, are dealing with these issues. I mean, the fact that we see the diversity in the streets, the fact that you see this administration reacting in a very reactive way to communities of color and trying to preserve power in some ways within a smaller and diminishing pocket of American society. Change is coming. And I think it's very clear when we see that in the messaging, we see that in the images that we see in the media, and even in the way that a lot of this is languaged about. So that's something that I feel is very encouraging.
So I've been trying to sit with those questions, and so I won't repeat. I'll just say ashe and amen and all the affirmations to Kenyon on the fear. And in the early stages of this, and even well, actually, as we started to get to the reopening conversations, that conversation started to happen. And so, and I'm glad we didn't like completely go down that road. But it is still a danger. What I'm hopeful for is our ability to explicitly state the things that need to change, right? And so there's the identification of the problem, which we are really good at doing, right? We have a lot of folks who are like, we have a lot of fire alarms, right? Like there's a problem. I am encouraged by seeing more firefighters, folks who are looking at the policy side of things and saying, these are the changes that need to be made. You know, there are folks who I know that I can't reveal because things are still in progress, but I know folks in different states who are working on policies on, you know, what does it mean to really make sure that police officers get held accountable, like when they do things, that they're in communities, people are organizing, not just in terms of protesting, but organizing in terms of what is our long-term strategy for how we hold our different kind of silos of power accountable with our power that we do have. And so I think for me that those are the things that keep me hopeful, as well as kind of seeing some of the visuals that are more symbolic, like seeing police officers march with protesters, right? Seeing police officers kneeling with protesters, seeing police officers make it easier for protests to do their marches. And so I would like to see us go the next level, which I think is sometimes where we miss the opportunities, which is the action, right? And so I'm hoping that all those firefighters out there are gonna be able to spring into action and be able to fully leverage this moment, so that the pain and suffering that has come before now isn't in vain.
So one final question related to all of what you said, in terms of the notion or the role of allies, and we've gotten several questions from the audience about that. And I'm gonna take a leap of faith and say that allies really means white people. It doesn't only, but I think primarily that's the question. And I just wonder what is your response to that? I have my own. There's a desire to have people really be on board and really be friends, allies, and there are people who are, of course, and who have been. But you know, for me, part of it is the question still irks me a bit. Even though as much as I welcome the question, it still irks me a bit. And I think that's real, particularly people of a certain age. But it's also the thing that we need most is for people to have allies and have everybody be on board, which I think we're seeing, and that may be how this moment is different. So I'm just wondering what people think about that question when people ask you, what's the role for allies, particularly white allies? What do you think in 1 minute or less?
I'll take an attempt first in 1 minute or less. So I would say I'm very careful about not calling them allies and using the word accomplice, because allies implies fun and friendliness and all that, and we need to be cordial and all those things. But again, there's danger involved, and being willing, there's sacrifice involved. You will lose friends as a white person when you side with positions that impact Black people. And I would say that there are also allies who are not Black that we also need, like our Latinx, Latine brothers and sisters, you know, who many of whom identify as Afro-Latino or Afro-Latina. We need our Asian brothers and sisters. Like we need all of the allies, because the reality is that all the things that we fight for as Black people, everybody else benefits from. It has been that way since the beginning of everything. And so, and I think it's not about, and to be clear that being an ally or an accomplice is not about saving Black people. We don't need to be saved. We can save ourselves if folks would get out of our way. But what we need are for folks to learn, to follow our lead, we need everybody to step up their racial equity literacy. That means I'm learning more about history. How did we get here, right? Like we need folks to learn those things. We need folks to learn how to give up being in control of everything. And we need folks to spend more time looking at themselves and how racism has been harmful to them in their white identity and their other identities, so that we can be in space together and not be competing with one another, and come from a place of genuine love for ourselves first and each other, right? And racism and oppression is a block to that.
Thank you. Anyone else? We have 3 minutes left.
Yeah, quick. I just would say, you know, operate from whatever space you're in, and you don't actually even have to live in a place that has necessarily a lot of Black people to be an accomplice, so to speak. So if you, you know, I mean, I think if you do, then, you know, the question becomes, in what places of power do you have? Do you leverage those things for, you know, racial justice, and not just diversity, but racial justice, in terms of your workplace, who's hired, who's on the board, and what roles, how much authority people have, how comfortable people actually feel challenging the status quo, right, without retribution. And also just in like people's personal spaces. I mean, you know, we look at what has happened, you know, in the last couple of weeks, just specifically. This has not been Montgomery, right? It's not been Jackson. It's Minneapolis, right? One of the like liberal bastions of the country, or in its kind of imagination of itself. And so to me, there's and also just kind of what happened in Central Park in New York the other day, right? And you continue to see, even in the so-called like North or whatever, these kind of progressive, you know, identified sort of blue state or blue city enclaves, this type of like, you know, just real nasty racism happening, right? And in the case of Minneapolis, the direct loss of life. But you know, even, so just to me, it's also about like, how are you challenging the white folks in your life to not use threats of the police when, you know, they are challenged in public, right? Or whatever else, right? So to me, like those kinds of things can go, I think, a kind of a long way as well.
Greg, any final?
Yeah, you know, I agree with all of those points. I think the one thing that I would add as well is that, you know, if we really think about it, most of us have some privilege in our lives in one specter or another, whether or not it's economic, whether or not it's by your gender or your sex or anything else. There are some, even among those of us who are people of color, there's some privilege that's there that we also might have to check. I mean, I was a women's history major in college, and subsequently became an epidemiologist. And I remember being in many spaces where you just had to live with the discomfort of being the only male in particular classes and spaces, and just sitting and listening and really trying to figure out, well, what does that mean? How do you be an ally to other communities that have been disenfranchised? So I think that, you know, in closing, you would just have to think about ways that, you know, don't ask others to do what you yourself are not willing to do in terms of being an ally, and in terms of using the privilege that you have to the betterment of other people. And I think that that's something that all of us can probably think about, particularly with everything that's taking place over the next few weeks.
Well, it is exactly the time for us to say goodbye to all of our guests. And to the panelists, thank you very much. This was a fantastic conversation, very therapeutic for me, I have to say, in this week. So everybody, thanks for joining us. We'll have another episode of the series in 2 weeks, so look for that. We'll be sending people information about it. So Kenyon, Greg, Atia, thank you very much, and be safe, everybody.